Good morning, everyone. Hello. So welcome and good morning to everyone joining us in real life, as well as those joining through Zoom today. My name is Amaya Calderon. I'm Associate Professor at the Aging Research Center of Karolinska Institutet and one of the organizers of this event. The symposium with the title Person-Centered and Integrated Care for Older People, Successful Experiences Across Sweden. So let me give you a bit of a background regarding the motivation behind this symposium. As recently stated by Iona Heath and Victor Montori in an opinion paper that they published in the BMJ, there are two possible solutions that could be put in place in the face of the current crisis of healthcare that is happening across the globe. The first solution, the first approach, is one that puts the emphasis on biomedical science and technology discovery, ignoring that care is only possible between people. The second approach, however, acknowledges that only humans and interactions can care, and that it is thanks to this human interaction that we can shift the focus from what makes living possible to what makes living meaningful. As the authors mention, efficient and safe healthcare is essential and only achievable through standardization, regulation, and training. But this is not enough. Careful and kind care are key in the face of failure, pain, decay, and death. That is, in the face of living. Careful and kind care are essential to attend to persons' biology together with the biography. According to Heath and Montori, post-pandemic industrialized healthcare is increasingly driven by numbers and at times futile interventions. And this is often at odds with the actual work of caring for the old and the sick. It is at odds with core values such as dignity, justice, solidarity, and even sustainability. There is no healthcare without care. And this is what today's symposium is about patient-centered and integrated care experiences that may not only delay disease and prolong lives, but that may simultaneously promote trust, care, kindness, and solidarity between patients and professionals, but also among professionals themselves. We have done this by bringing together different experiences across Sweden, a country that has a tradition for caring for its citizens and also its older citizens. Today you will be hearing different speakers from the Royal Institute of Technology, Örebro University, Mälardalens University, University of Gothenburg, Linnaeus University, Lund University, Sahlgrenska Academy, Karolinska Institutet, Region Jönköping, as well as the Swedish Agency for Health and Care Services Analysis. We hope that you enjoy it. None of this would have been possible without the important economical support received by JIM, the Journal of Internal Medicine, and Forte, the Swedish Research Council for Health, Working Life and Welfare. Our deepest gratitude goes to them. Now, before giving the word to today's keynote speakers, I would like to welcome and give the word shortly to two very special persons linked to today's event. First comes Bo Angelin, professor in clinical metabolic research at Karolinska Institutet and editor-in-chief of the Journal of Internal Medicine. And second will be Maria Eriksdotter, professor in geriatrics and dean of KI South. So, Bo, welcome, and the floor is yours. Thank you.
Okay, thank you very much, Amaya, for these kind words. I'm just supposed to give you a short introduction to one of your new friends, and the friend is Jim. And why do you have friends? Well, friends are there to help you, and they are also there, of course, to enjoy the fruits of what you might be achieving with the help you get from us. And in order to introduce Journal of Internal Medicine, I would first like to introduce you to Axel. So this is Axel K. And Axel Kay is an interesting guy, or was at any rate. He was actually the head of the Karolinska Institute in the mid-1800s. And he was professor of pathology. He was actually the cousin of Ellen Kay, who to more of you is probably better known. But Axel Kay was a very successful scientist, but he was also very smart when it came to organization and planning. He happens to be a personal friend of Alfred Nobel, and it is not probably unexpected that he had some influence in why Alfred Nobel divided his will in the way he did. But he also realized that if we wanted to become an international university, we need to publish. And he felt that Swedish scientists were not publishing very well. So he founded a journal. And the beginning was called Medicinskt Arkiv, or actually, well, it's probably in Swedish, but most of the stuff was written in German by those things. And that was 1863, so that's 160 years ago. And that actually makes it one of the oldest medical journals in the world. And it was then changed into Nordiskt Medicinskt Arkiv. And from 1901, it was called Acta Medica Scandinavica. And some of you might have seen that journal, because that journal was going on for a long time. And in 1989, I was actually involved as a young scientist in order to reformat this into a modern journal. And we were able to take the name Journal of Internal Medicine, and it was supposed to become a journal of anything related to medicine, and actually becoming a little bit more international. But the other thing that is important here is that Axel Kay also realized that if you run a journal, it will give you a deficit. So he instituted a fund in order to cover to support, so to say, the losses of the journal. And actually, the journal is making a profit. So we actually have a very old fund that has been growing all since 1863. And that has to be used in order to support the journal. And one thing that we happen to support is actually organizing meetings. So this is just to remind you that we are running papers from everything, I would say, within internal medicine. We're particularly interested in experimental work in humans, but we also study epidemiology, different treatments, etc., etc. And as you can see here, we have a number of editors working here in Stockholm. And Laura Fratiglione, who is a co-organizer of this meeting, joined the editors this year, actually. And we have a small red house just outside Tomteboda, the old blind institute, is where we have our office. And we have some people here that you can talk to about these things. But anyway, just to remind you, this is a nice journal. It comes out once every month. We get about 1,500 submissions per year. We have a relatively tough sorting out, so our rejection rate now is about 90%. We've been pretty successful, so we actually rank among the higher journals when it comes to internal medicine. Obviously, New England Journal and Lancet are number 1 and 2. We're number 16, which we're pretty proud of. And we have open access, which is important, that we're actually doing that in order to make it even more broad. And what I can tell you also is that we can help you organize symposia. Generally, we want to have some kind of publication of high quality that we could even that with, so we're looking forward to this meeting. And you can also get help if you want to organize a think tank. And I think this meeting started with a think tank supported by us. And you can look at our homepage on that. And this is just to understand that we organize. This is one type of meeting. We're also organizing later in May a meeting in Okinawa to look at what is the background on the blue zones where people seem to live forever without making very strange things, actually. So we're bringing the best people from the world on longevity onto Okinawa, and then they sit there for two years and hopefully make us a good paper. won't tell you this, but I think if you want to know more, you can just visit this homepage and look at it. So we are very proud to be able to support this, and we wish you all luck, and we will follow this. Thank you very much, and welcome to all of you.
My name is then Maria Eriksdotter, and I'm the Dean of Karolinska Institutet South. And I'd like to, on behalf of Karolinska Institutet, I'd like to welcome you all to this very interesting, and I hope fruitful discussion and symposium day. Karolinska Institutet just recently welcomed their new president, Annika Östman Wernersson, and she gives her greetings to you all. So our greetings from her, and she has said that our research and education are incredibly important for contributing to people's health, both nationally and globally, and that is what we're going to do today. Since I'm also the Dean of KI South, I just take the opportunity to tell you that KI has 4 campuses. We are now present in the main campus here at Solna, but we also have a larger one also in Campus Flemingsberg in southern Stockholm. And that's where I'm as a Dean of KI South actually are working, and we have 6 departments there. And there you are very close to the healthcare system, to the Karolinska University Hospital at Huddinge, as is the main campus here is also close to the Karolinska University at Solna. Then we have department at KI at Södersjukhuset and one department at Danderyds Hospital. And I think this illustrates a very important part here, which I think also will come up in the discussions, hopefully, that we need to also interact a lot with the regions, and with the municipalities. So KI also has connections, of course, with primary care, but also with the municipality. And I think this is also very important for all the universities in Sweden. And I also think what we need to do is also to strengthen the connections with primary care, but also with municipality, with kommunala vården, and also do more research and education in that context. So I think that's an important message. Our vision at KI is we're advancing knowledge about life and strive towards better health for all. And this is also what we're going to talk about today. And today we focus more on the older population. And me also as a geriatrician, I think that is very important. There is a lot more to do for improving health of older people. And also KI, which has a lot of different, of course, areas of research, but the area of healthcare sciences and aging is actually also increasing and being much more important at KI than it used to be several years ago, and I think this is also a very important part. I'm looking at this, so no, let me see. So another thing which I think is important is that we have multidisciplinary interactions, we have interdisciplinary interactions, so collaboration in science is the key for success, which I think many of the talks today will focus on. And also, of course, innovation and entrepreneurship. And I see that also in the symposium, lectures. So this is, I think, the key for success. And then finally, I just want to be on a bit more personal note. I'm also the registry holder of the Swedish Dementia Registry, SWEDEM. And we are looking or studying or evaluating quality, care indicators in dementia care from diagnostics to late care in nursing homes. And one thing, for example, that we have nursing indicators in persons with dementia, where we have, for example, our individual physical environmental adjustments documented in the individual care plan. We use that information. And we see that in those nursing homes that were affiliated to SWEDEM in 2016, only 50% use this type of information. But now later on, it has increased to 70%. So these are also things that we can do to improve care, and I think this is just one part, but I think we need to do much more research about this area and the importance of person-centered care, the importance of integrated care, and I welcome you all today to this really important symposium, and I'm looking forward to learn a lot about this. And very welcome from KI. Thank you.
Now, it's finally my great pleasure to introduce you to today's keynote speakers. So we will start with Anne Hendry. Anne is a geriatrician and senior associate with the International Foundation for Integrated Care and the director of IFIC's Country Hub in Scotland. From 2007 to 2016, Anne held national clinical lead roles in Scotland for policy and improvement programs on long-term conditions, healthcare quality, reshaping care for older people, and integrated health and social care. So this experience developed her passion for cross-sector collaboration and skills in implementing and evaluating transformational change in diverse health and care systems. Thank you very much, Anne. The floor is yours.
Thank you. Thank you so much, Amaya, for that kind introduction, and it's a huge pleasure for me to join you today. We've already heard that care is all about compassion, it's about collaboration, and I'm going to share with you some of the background on integrated care. I'm also going to start with saying that integrated care itself is intrinsically people-centred. We're going to hear this morning about integrated care and then about person-centred care, but the two go hand in hand together. Integrated care is an experience of care. It's not a process. It's about what's experienced by people and by communities. So it's about population health as well as person-centred care. And it's a route to developing the quadruple aim, which is our sort of desired shared outcomes of integrated care: better population health, better experience of care, both as someone who uses services and as a provider, and more cost-effective care. There's many frameworks about integrated care that you can read, and there is no perfect framework. I'm sharing a couple of examples of my favourite ones. The WHO Global Framework on Integrated People-Centred Health Services very much has empowering, engaging people and communities at its heart. And the more recent 9 Pillars model by the International Foundation for Integrated Care also has a section on people as partners in care, and also population health and local context is so important that, you know, I absolutely agree about reaching out and understanding the role of the municipalities in integrated care. And I'm thinking about resilient communities and new alliances with partners beyond health and social care, with communities and local citizens as partners. The essence of integrated care is continuity and coordination of care. And the WHO practice brief on continuity and care coordination was the first practice brief to be published to support the implementation of the global framework. And it gives many examples of continuity and care coordination across the globe, including in developing countries. And a Health Foundation document makes the point that care coordination is absolutely critical for people who are old and are more vulnerable, because they often experience the worst fragmentation of care and support. And we know that poorly organised, poorly delivered care is very expensive, not just in terms of harm for people who receive services, but also for the system. And I'm very fond of this particular slide, which shows the level of fragmentation of the system for somebody who's receiving care and support. For Malcolm and Barbara, how do they navigate their way across the range of services and providers that are required to work together in order to help them live a good life? And that's because older people have multiple conditions, multiple physical, cognitive, sensory impairments, and require care that is intensely biopsychosocial, not just the biomedical type of care. And that care can be fragmented for people navigating the system, but it can also be terribly difficult for ourselves as providers of care to navigate that system. When you ask older people what matters to them, what comes back very clearly is they want joined up care. They want care that is coordinated and helps to understand what their needs are and gives them a sense of control. So integrated care is really all about those things. And the I'm still me, I statements are very much a narrative around what good care looks like for older people. And the reason that's really important, we have to remember, is that older people are not homogenous. We're all different, and older people are no different. They are a range of very fit, active, healthy individuals to older people who are living with frailty, who are particularly vulnerable because of impairments of their functional ability. And we need to start thinking of frailty as a long-term condition, which can be prevented, and which is best addressed by the chronic care model. Understanding where people are in the continuum of being fit to mildly frail, to more moderate frailty, or severely frail. So we're now looking at integrated care as a population health approach. And the population health model uses data to help segment your population into different levels of complexity, different levels of intensity. And this is an example of a population health approach in one municipality in England. This is from my colleague David, who has been working with his primary care partners to segment their population and to understand what are the tailored interventions at each level. They use the electronic frailty index in primary care, which is an algorithm which automatically uses routinely collected primary care data to begin to segment the primary care population into people who have mild, moderate, or severe frailty. And that's really important because they have very different outcomes in terms of their individual health outcomes, but also in terms of the cost to the health and care system. So it is possible to take that segmented population health approach. It's also possible to do opportunistically. And we have the lovely Rockwood Clinical Frailty Score tool, which is very simple, very easy to use to identify older people who are living with frailty. But the reality is, when you ask primary care and community professionals, are they using this tool on an ongoing basis? The reality is often no. And community nurses in particular are extremely well placed to be able to opportunistically identify people with frailty, but yet they often don't have the time or don't have the confidence to use the tool. We're now beginning to talk about integrated care for older people, not as a pathway of care, but as an integrated wraparound model of care, an ecosystem that you wrap around older people, bringing together the range of professionals, providers, and community supports and services that you wrap around older people. And this paper from our European Frailty Prevention Approach project, the Advantage Joint Action, is this end product of 23 countries working together to design and develop what good integrated care for older people would look like. It's quite an intuitive model, which is based as a primary care entry point, using simple screening tools, and then delivering the evidence-based comprehensive geriatric assessment. Individualised, personalised care plans, and we'll hear more about that, I'm sure, from Professor Brendan, and a case management model, coordinating care for people who are particularly vulnerable with intensive support needs. I run through just a couple of examples of the different stages or the different areas of care. So, for example, well-being in later life, some work that we've been doing in Scotland, has taken the 5 ways to well-being, which I think has now got quite international recognition, but recognised that for older people, eating well is hugely important. So we've added nutrition and eating well in later life to those 5 ways to well-being. And we recognise that the ways to well-being are grounded within age-friendly, compassionate communities that help people to live well and are supported by digital, day-to-day digital technological solutions which help people to manage their conditions. In Scotland, anticipatory care, care planning that thinks ahead and helps people to understand their preferences and articulate their preferences for future care has been at the heart of our work on integrated care. And that's been taken forward alongside polypharmacy reviews of the multiple medicines that older people often take in later life. And what we've done in Scotland is we've tried to shift that curve left. We've tried to move our focus from hospital and institutional settings to much more upstream community-based interventions. And we've tried to change the focus of care from reactive to more proactive care and support. Very similar to what my colleagues in Catalonia have been doing in their proactive, person-centred care programme. And a few months ago, I had the privilege of joining with them to see what they were actually doing in the primary care setting, where they work together as a multi-agency team, but also pull in their hospital at home and their palliative care services within the locality. And then at the 3rd level, they engage at the interface with hospitals. Another example of integrated care at a national level could be from the Republic of Ireland, who have a national programme for older people. And that national programme, at the heart of it, is a case management model, the care coordinator for older people. Closer to home for yourselves, I think a great example from South Karelia, where they've got a regional network of services wrapped around their older population. And the reform at the moment in Finland is very much moving towards a regional network of services across municipality, primary care, and hospital services working together. I'm looking forward to hearing more from colleagues in Sweden about what you're doing in integrated care. There's lots and lots of information that you'll be able to access from the WHO documents around pathways, practices, and how to organise your system. And it's important to remember that integrated care is also about long-term support for older people. And I'm a great fan of the new framework for long-term care, which sees it not as a service, but as a system that is wrapped around older people and works in partnership with unpaid carers and with the voluntary sector. Integrated care is all about people, it's person-centred, and it's about the people who deliver care. It's people who bring integrated care to life, so it's really important that we develop the capability of our workforce. All of our workforce across the whole system, whether you're working in specialist services, in primary care and community services, or whether you just occasionally come into contact with older people with frailty, it's really important that everyone has the confidence and the skills and the capability to do the right thing. Thanks very much for the opportunity to engage and to sort of set the scene for the day. I look forward to continuing to collaborate with this learning community, and I hope that some of you might join us at the International Conference on Integrated Care in Antwerp in May, or stay connected through our online international special interest groups and webinars. Thanks very much.
Thank you so much, Anne, for a very comprehensive and pedagogical and inspiring presentation. Thank you. So next comes Brendan McCormack, who will be joining us online today. Brendan is professor in nursing and head of the Susan Wakefield School of Nursing and Midwifery and Dean Faculty of Medicine and Health. Brendan's research focuses on person-centeredness with a particular focus on the development of person-centered cultures, practices, and processes. He has engaged in this work at all levels, from theory development to implementation science, and through to instrument design, testing, and evaluation. In 2015, he was recognized as an inspirational nursing leader by Nursing Times, and most recently, Brendan was featured in the Wiley Publishers' Inspiring Minds short film series. So Brendan, welcome, and the floor is yours.
Thank you very much. And it's wonderful to be with you all this morning. I'm in northern New South Wales in Australia, where it is now 7 o'clock in the evening. So this is the second half of my day, but it's wonderful to be able to join you. And sorry I couldn't be there in person. In the short time that I have, I want to talk about person-centered care. But I guess more explicitly is to talk about person-centeredness as a practice, and ensuring that we are focused on the whole system, as Anne has just been talking about. And I totally agree with her. Integrated and the person-centered care go hand in hand, and hence the reason, I guess, why we've been asked to speak on the same platform. So in this time, I just want to talk a bit about person-centered practice and cultures, and talk about some of the things that I think are important in dementia care specifically to be paying attention to. I'm not going to labour this too much, but we all know that contemporary healthcare, again, as Anne has been illustrating through the global work that WHO and others are developing, contemporary healthcare is very much focused on being more person-centred, and is now much more of a language within contemporary healthcare discourse. And I guess it really reflects this movement away from our health systems that are about task orientation, about achieving tasks, about getting persons through a system as efficiently as possible, and in that process actually dehumanizing people. And we have ample evidence from all over the world of that dehumanization process and how easily it can happen when we view people as a series of tasks that need to be undertaken, and where we view systems as being there to efficiently get people through a system. And so person-centeredness is really about challenging some of that and creating a discourse that is about putting the person at the center of care decision making. I update this slide on a regular basis, and some of you will have seen me use it before, because I use it to illustrate the amount of work that is going on globally in the development of person-centered healthcare. And of course, it does very much intricately connect with the work that people like Anne do around integrated services, and the work that the WHO does in very much promoting the person at the center of integrated services. But we can see from this slide that there is a huge amount of work happening around the world to really rehumanize healthcare. But I wanted to say a little bit about language. And one of the things that troubles me a lot in this space is where we use the word patient-centeredness and person-centeredness interchangeably. And I always am interested in this because even up until yesterday, I will give a lecture where I just talk about persons and person-centeredness. And the first question I'll be asked, they will use the word patient. And it's as if we use these things interchangeably, as if they are the same thing. And what's important for us in terms of the language of patient versus person is about what it means in our discourse and what it means for practice. It's not just words. Patient-centeredness, yes, has the patient's values at the center, but it is still very much a professional-driven ethos. It is about the professional respecting those beliefs and values of patients and families and communities, I would add, but it is a professional-led and directed process. And the thing that I guess I am most concerned about is that patient-centeredness has as its primary focus the outcomes of care for patients and families. And yes, that is, of course, really important. But what it neglects to recognize is that we can only achieve those outcomes if we apply those principles right across everyone who's providing this care. And so person-centered practice for me and for the work that I've been engaged in for nearly 30 years now has been about seeing it as a culture. There is no person-centered care without a person-centered culture. And we have to be really clear and explicit about that. It is unsustainable to think that we can provide patients and residents and others with person-centered care on a continuous basis if we do not create the cultures of care that will support that. And in our work, we describe that as healthful cultures, cultures that are energy giving, that help me to be the best that I can be in the work that I'm doing and in how I am connecting in the services that I am delivering. For our work, we have been working with person-centered practice framework for 25 years or so, and it reinforces what Anne has been talking about as well, and that we have to adopt a whole systems approach when thinking about the delivery of person-centered care. Again, reinforcing we cannot do the care part, which is the 5 petals of the flower in this diagram, if we do not pay attention to the outer rings from the macro context through to the competencies of staff, plus the context within which staff are working in order to provide this kind of care. And so we really need to see this as a whole system and not just in terms of how we provide individualized care to persons. And this is also important in the context of the staff who are providing care. And I'm going to focus on nursing just for a minute, because we know that there is a global issue around the nursing workforce. And here in Australia, that is as acute as anywhere else. We know that here in Australia, 1/5 of the nursing profession will leave their roles in the next year or so. And there is a global shortage of nursing. And that has been recognized by the International Council of Nurses and many others. And this research that was undertaken last year by McKinsey and Company, which is a global human resource company, and this is the Australian data, is about why is it that nurses are leaving their job. And we can argue about COVID and the impact of pandemic. We can argue about salaries and the problem of pay and all of it. But if you look at this scale, which was from one question that McKinsey asked nursing staff about what would influence their decision to stay in their role, and you can see that the top ranked items are not to do with pay and are not to do with COVID and pandemics necessarily. But the number one reason that would keep somebody in their job is having a caring and trusting teammates, followed by being able to do meaningful work, working in a safe environment, being valued, etc. And all of these qualities are qualities that we argue are central to the provision of a person-centered service. And so when we think about providing person-centered care, we cannot just focus on what is it that patients or residents or people are receiving. We have to think about that context and how are we providing that culture that enables staff to do this on a continuous basis. We also need to see person-centeredness in a social model. And again, I think Anne has really demonstrated about how an integrated service pays attention to, yes, the healthcare needs of people, but also places that health in a social context. It places that health in the context of social relationships and how we develop these interrelationships and interagencies in order to provide the best possible care. And I would argue very strongly that if we are going to achieve that within the world of dementia care, we have to see it as a public health priority as well as a long-term condition. And when we see dementia as a public health priority, we see it within a social context. It's not just about the care that somebody might receive in a particular care setting or facility, But it is about the whole social construction of dementia, the whole social systems that are supporting that person, their carer, their extended family members, etc., in enabling them to live a meaningful life. And so how we see provision of person-centered care to people living with dementia is really predicated on how we view the whole system of care and the way we apply person-centered values at each level of that system. However, in reality, we all know that there are huge challenges in achieving that. And I've tried to summarize these in the interest of time down to 4 key areas. One is that within our systems, we still organize care largely around physician-centered models of care, around diagnostics, around treatment plans, and around how our services give us access to those physician-centered models, and not to a whole system of integration. We also know from extensive evidence that our cultures of care are continue to be largely paternalistic and controlling. Today, where I am in New South Wales, I went to visit an aged care facility where we have some students. There are very few people in that aged care facility who have advanced dementia, but yet the door is locked. When I question that, it's to do, they argue it's safety, but actually I would argue it's more about control. It's more about the model of care and the decisions we are making to control people's lives. I've already emphasized the workforce issues and how we ensure that we have a person-centered workforce. Lastly, but by no means least, because it is central to integrated practice, is interdisciplinary working. Again, the reason why I'm here in Northern New South Wales to look at the interdisciplinary practice education that's happening here to try and advance a more social model version of aged care. But there are also challenges for staff within that context. And some research we did back in 2013, we identified that most, in this case, older people, did not receive person-centered care, that at best what they received was person-centered moments. And that these were really important, meaningful moments in a person's life when they felt loved, when they felt cared about, when they felt that they were being treated with dignity, compassion, respect, etc. But in between times, they didn't feel that. They felt like they were being treated as an object. And that was largely to do with the model of care, with the busyness of staff, with the way that staff were allocated, and with the way that teamwork, etc. happened. Again, all of those characteristics that I've identified in the person-centered practice framework that need to be given attention to. And if we are going to be serious about person-centered care, we have got to get away from being happy with person-centered moments. We have got to think about how do we turn those moments into meaningful experiences of care over prolonged periods of time. And that is about us being therapeutically effective. And again, in dementia care, there is ample evidence of innovations that are focused on increasing therapeutic effectiveness for persons living with dementia. And here I've listed some examples of themes from work that has been going on for 10, 20 years of innovating within the dementia care space to try and create more effective person-centered cultures. And the last on that list is around technology and technologies of care, which is a hugely significant focus in our current healthcare provision. But I would also want to argue that even with those innovations, we do need to really think about how we measure outcomes, how we measure outcomes for persons themselves, how we measure outcomes for people who are providing care, and how we measure outcomes for the services and the organizations that are funding care. I think it is really important that we give consideration to what we pay attention to in relation to the areas that we measure in terms of effectiveness. I would argue very strongly that we need to move to a much more theory-based model of evaluation, where we are using frameworks like the person-centered practice framework or the integrated care frameworks to really think through whose outcomes are we measuring and how we pay attention to particular aspects of services, because it is those that we privilege, and we need to think about the way we privilege all parts of that system if we are going to get sustainable person-centered services that are effective. And in the work that I've been engaged in, earlier this year, I was challenged with identifying the impact from the work that me and my collaborators have been involved in. And it was a really interesting exercise to do, and one that I took some time to bring together, but actually which was quite interesting to see the work mapped out. And in this slide, I've just shared some themes where adopting a more whole systems approach to development of person-centeredness has had impact both in aged care, in the acute care sector, in the development of palliative care, particularly in the aged care nursing home sector. Looking at intervention studies and how they can kind of start to help us to understand how we shift some of the environmental issues that we need to be paying attention to in order to shift culture. But also, the most recent work that we have just finished last month is the development of the first pan-European person-centered practice curriculum framework for healthcare professionals. Because if we are going to shift some of these cultures, then we also need to think about how we are educating our future workforce. Are we educating them as person-centered practitioners, or are we educating them as highly technically competent practitioners where person-centeredness is a secondary concern? And I think that is a huge issue for us within the university sector to give serious attention to if we are going to make substantial shifts in how people receive care. So to conclude, person-centered care and person-centered cultures for people with dementia is now an uncontested space. Everyone recognizes that is what we have to strive for, and it is an important ethical and philosophical concern. But it is not something we do as one-off projects, and we need to think beyond individual projects and how we develop sustained commitment from organizations for the development of these kind of care and services. I would really want to encourage us in the discussions that you have today to think about shifting our lens from the responsibility of individual practitioners for the provision of person-centered care to the responsibility of organizations for creating the conditions to enable those practitioners to practice as best they can. And that is where I do see we have significant work to do. We have a lot of rhetoric and we have a lot of espoused philosophies, but actually at organizational levels, we still see a lack of person-centered commitment and a continued focus on it being the individual practitioner responsibility. So if we are going to shift that, we need to do so quickly, and we need to do so by using methodologies that help us to sustain these services and to move it away from being fragile and transient, and that is dependent on the quality of the staff who are in post at any one time. Thank you.
Thank you so much, Brendan, for a beautiful presentation. We actually finished a bit ahead of time. We have 8 minutes. So I was wondering if you could stay there 8 minutes and Anne could perhaps come to the front. If there is anyone in the audience who wanted to take advantage and ask any question now that Anne and Brendan are here.
Johan Fritzell from Aging Research Center at Karolinska. First, a great thanks for excellent presentations and inspiring talks. And I think my question is mostly related to Professor McCormack, but maybe to both of you. I mean, my sort of evaluation of how integrated care has been sort of on a topic discussed, and everybody is in favor, as you said, for 25, 30 years, but still we haven't seen so much progress on the sort of more upscaling of local projects. And I think the pandemic clearly shows that there is a lot to do in integrating social care and healthcare, not least here in Sweden, I would say. But what would you say, you touched upon it, but what would you say would be what is the main obstacles for upscaling? And secondly, what is the role of the research community, or is it beyond the research community, so to speak?
Do you want me to go first?
Yes, go ahead.
Okay. Thank you for that. And I think it's a really, probably the most significant question we may want to address. I think there are a number of things I would say. I'll start with the end question about, is it beyond the research community? And I would say absolutely not. I think the problem I have with the research community, and I'm in this space myself, is about the methodologies we are using, which I believe are not embedded enough, are not innovative enough to really unpick some of the nuances that are really important for us to understand about how we shift some of the cultures and systems change that needs to happen within our services. And I do think the focus on implementation science does help us to move towards that, as long as we don't focus implementation science purely on doing more trials of interventions, because that, as the WHO themselves argue, is only at the very top of the contextual pillars and the contextual pyramid. There is a whole myriad of work going on underneath that requires much more collaborative, creative methodologies for us to understand. So we really, really need to be in that space. In relation to the other part of your question about what needs to be paid attention to, I think I would go back to the last comment I made in my presentation, which is that we have focused for far, far too long on the competencies of individuals to provide person-centered care, and really let organizations off the hook in relation to their responsibility to develop structures, systems, and processes that enable person-centeredness to be at all levels of the organization. So in terms of funding, and the divide between health and social care funding is a huge issue in relation to human resource frameworks, in relation to some of the strategies and policies and how they are imposed and not developed collaboratively and embedded, and then how we use organizations almost as a lever to support people in these cultures. So I think it's about the lens and what we're focusing on, and we really do need to shift our focus in person-centeredness terms to much more of a whole systems, much more of an organizational macro level space. I'll stop there.
So I would support that. I think it's so much easier to do some research on individual components of care, like care planning or case management. It's much more difficult to study and to scale up a whole system intervention. And we need to recognise that what works in an urban setting might not in a rural setting. So it's not a case of one size fits all, even within a country like Sweden. Scotland has very many islands, so what works for our island communities and some of our remote and rural communities is absolutely not what's going to work in Glasgow or Edinburgh. So system studies are where we really need to get to, and as Brendan said, looking at mixed methods, realist evaluations of what works and how and who and where. So that's what it's going to take. And it also needs to recognise that this is a long game. You're not going to change a whole country health and social care model within a few years. And we also need to have political and funding levers and professional contractual levers that are aligned at the same pace of change, and that's incredibly difficult to organise. It's not impossible. We have shown in Scotland where we've been able to make some progress towards those steps being aligned, but it's a big, big challenge, and I'm sure a challenge that we'll return to over the course of today.